Good morning, everybody. Good afternoon. Thank you for joining us this morning. We really have a great talk lined up for you. We did a great talk last week on tips and tricks in TAVR, and now Antonio was kind enough to do this presentation, which I've seen some of it once before. It was one of the best presentations I've seen him give. I always said I wish he had given me this presentation when I started my fellowship instead of years later, because there are lots of very important tips and tricks in this. So thank you for joining us. Antonio, grazie mille. Thanks for doing this.
Okay, thank you, Azim, and thank you, Eberhard, and Yuan, everybody. So, top lessons I learned from the Cath Lab, and no study will ever show. Maybe some study will show. Plan the procedure and have clear your goal. If you are doing a coronary angiogram, your goal is to see the coronaries well and to make a diagnosis. Make sure that you know why you're doing something. Do not want to treat the lesion in a specific fashion to demonstrate a technique of a device? Question mark. Yes. Do you want to show a specific approach? Do you want to treat the lesion in the most simple way to get a good result? I believe this last statement should be our goal. Whatever is your plan, make sure that you do not put the patient's safety at risk and you do not compromise the result. So, safety and result. You cannot be safe unless you get also a result, because the best way to be safe is doing nothing. So if you want the result, you have to have the result, not only safety. Radial or femoral. Have very clear the advantage of a limitation of each specific approach and the specific skills you have. Results of randomized studies are important, nevertheless, specific settings are more relevant. Femoral, do not increase the mortality. Increase the mortality overall in a general study, but in the specific patient, the mortality is increased by doing something that is not appropriate. Consider closure device when femoral. Do not lose your skill to perform femoral puncture, and if you do not have the skill, you should learn as soon as possible. Femoral is an essential technique and should not be replaced 100% by radial. Guiding catheter. Always look for the best guiding catheter. There is no substitute for optimal support. And do this at the beginning of the procedure, not after you spent half an hour to deliver a stent and then you realize that you don't have support. In some situations, use a diagnostic catheter first and then exchange to guide with a wire in the coronaries. Diagnostic catheters sometimes are the best way to unlock the left main. Place an additional high support wire, Graslam, Sion support, whatever, in another coronary vessel to gain better support. Guide liner or other selected catheter are important, but they are not a substitute for appropriate guiding catheter. We did PCI for 25 years without guide liners. So this doesn't mean that they are not useful, but they are not a substitute for a good guiding catheter. These next 3 or 4 slides have been taken from Jeff Moses. I keep them because they are really nice. Catheter and wires are meant to glide through the body. Remember, it is a self-lubricated environment. Use small movement, orthogonal displacement or friction. You can only push on an object running over a previously placed wire. If you find unexpected resistance, pushing is not the solution. In case of an adverse event, hypotension, think about occlusion, aortic regurgitation caused by the guiding catheter. This is an underlooked complication, but always look is the guiding catheter too low. Bleed, anaphylaxis, drug. Arrhythmia, wire or catheter placement, chest pain, occlusion, no reflow. If there is bleeding, pain, hematoma, resolve it before starting the intervention. If not, the case will be a nightmare, either now or later. Do not go unless a complication has been resolved. If things look great and the patient feels bad, look again harder. As I said, listen to the patient. Bifurcation, which strategy would you take? Culotte, decay crash, mini crash, V, tap. Do not assume that any bifurcation should be treated by decay crash because decay crash has shown better result versus culotte. Each bifurcation can be treated, should be treated with the appropriate technique. Then randomized studies should be kept in mind, but these are not the way to tell you how should you treat this specific bifurcation that you have in front. Dissection eye complication if caused by the guiding catheter or if you run out of stents. But dissections are induced by lesion dilatation, are part of the dilatation procedure. Many stenosis dilate and produce a dissection, and that's the way to produce a dilatation. Learn to distinguish a benign from a malignant dissection, and be ready to leave some dissection without stenting. I know that this is a sin, but sometimes you should leave some dissection without stenting. Sorry for this statement. Benign dissection, no angiographic reduction of the lumen, contrast clear from the lesion very fast. IVUS shows the larger residual lumen despite the presence of a dissection. These are just added yesterday. Residual pressure gradient less than 10. Most of the people would not believe. That's fine, it's okay. This is a typical example of a bad dissection, right coronary artery treated with a stent, balloon burst. You see the nice staining of the wall. You have a dissection, long dissection, and you see that the lumen starts getting small and content is pushing on the lumen. When you do IVUS, you have a confirmation there is a hematoma. This dissection, you don't even have to measure the gradient. Most probably you don't even have to do IVUS, you stent. That's clear cut. These are general statements. Sometimes I tell them for joking, but there is some truth in that. If you suspect to be subintimal, I believe you are most probably subintimal. If you think you need the hemodynamic support, most probably you need it. If you think you need the rotablation, most probably you need it. So these are very inexpensive ways to make decisions. Balloon inflation. Learn when use semi-compliant versus compliant balloon. Avoid short inflation. Inflate balloons and stand for at least 20-30 seconds. And check for full balloon expansion in a couple of projections. And be ready to use additional device if you are not happy about balloon expansion. When under expansion despite high pressure, I like to perform IVUS, not to know that I have under expansion, that's clear, but to know the vessel size mainly. So then you can use shock wave, you can use laser with contrast, you can use very high pressure balloon, OPN, you don't have it in the United States. You can use cutting balloon, I like to inflate it at high pressure, of course, so you can use rotablation. Now you can also use orbital atherectomy in US. A rotablator can be used following incomplete balloon expansion, even if there is a dissection. A dissection is not a contraindication. You have to be a little bit careful, but it's not a contraindication. Angioscalp and cutting balloon should be inflated at high pressure, that's what I say, not instruction for use. But remember, they are semi-compliant, so they need to be slightly undersized. This is a typical example of a lesion not fully dilated. You see the lumen is small, angiographic, it doesn't look so bad. After OPN, at, I think was inflated at 40 atmosphere. Yeah, you see nice lumen. This is not always free of complications. Sometimes you may have a vessel rupture. So be a little bit careful, especially about sizing when you use the super high pressure balloon. ELCA, laser, you don't really need to have laser in the Cath Lab, but just for the sake of completeness, when you have stent under expansion, you can go with laser inside the stent, inject some dye, this is the typical balloon under expansion. You go with the laser, 0.9, 80-80, maximum fluency and repetition rate, energy, and you inject some contrast only inside the stent, and then you go to high pressure balloon. This is a very elegant procedure for people that have laser. They can use it 3 or 4 times a year. These are the result, of course, optimal balloon expansion. Difficult to deliver the stent, body wire. In the United States, you have the wiggle wire, the wire with ondulations. A short stent, also a short stent is a pretty simple solution, body balloon, and of course a guideliner. This is a typical example, right coronary artery, very tortuous, suboptimal guiding catheter. Maybe you should get a big Amplatz guiding catheter to solve the problem. If you don't have it, or if you cannot cannulate, you can use a guideliner. But remember, to effectively use the guideliner, you also need some support from the guiding catheter. Here you see a guide that has been Amplatzt against the aorta of the opposite wall, needed to well advance the guideliner. Sometimes you can go with the balloon, distal inflate the balloon and pull. That's another maneuver that you need to put into action. Contemporary complication. I believe vessel rupture or perforation and no reflow are the worst contemporary complications. For these complications is suboptimal. Even surgery is suboptimal. So they need to be solved by you. You need to solve these complications. Emergency kit for perforation and rupture, cover stent for rupture, coils and delivery catheter, microsphere, embosin for seronova, what we like, but you can use other device. Learn the diameter of the delivery catheter for a specific particle, usually 100 microns for 0.14 compatible. You need coils and cover stents. You may not need microsphere, but coils and cover stents are both essential. It is always better to occlude the perforation distally. Be very stingy to take care of a perforation by occluding the feeding vessel with a cover stent. Sometimes the perforation is supplied by collaterals and comes back after a couple of hours. If you have occluded the perforation distally with a coil, this issue is taken care of. These are the coils, different size according to the microcatheter you have. We like a seronova, but you can use whatever you like. These are different guide wires with the pushers, platinum coils. These are from Target Therapeutic, but again, you go in your radiology department and keep some of them in the Cath Lab, because when you need, most of the time you don't have the time to go down in another department to find for the coils. Rescue from massive perforation, do not hesitate to add a second guiding catheter. You need to keep a balloon inflated, get the other groin, and use a ping pong technique, the way they call it. In some perforations, this is not a perforation, this is a calcification of the mitral annulus, but you will see a perforation very soon. This severe calcification, balloon angiosculpt, non-compliant balloon, aggressive dilatation. Maybe if you did rotablation at the beginning or shock wave, you didn't have this problem. But after multiple attempts, you get a balloon rupture. The balloon was not optimally prepared, so the compressed air pushes the dye out and you have this perforation. When you have this perforation, the first things you do, you inflate the balloon. This is a nice LAD. By keeping the balloon inflated, you may try to get the guiding catheter down, advance, like a guide liner, and then quickly deliver a cover stent. This is a very quick maneuver that should be kept into consideration. If you cannot, you keep the balloon inflated, you place a second guiding catheter and you do the ping-pong technique with a cover stent. Here we place the meta stent first, then a cover stent, and then the perforation is taken care. So, but the maneuver to inflate the balloon at the rupture and keep these as an anchoring to get the guiding catheter selective should be always tried first, because may work and save you the factor to doing the ping-pong technique. And this is luckily taken care. This is a more dramatic perforation with less enthusiastic result. This is a circumflex rotablation. The wire went around in places where it should not go. And you see when you have this loop, something happen, and you see a massive perforation. It is very difficult when you have these big entry point, large entry point, to regain the distal vessel to put a cover stent. We tried, but we were totally unsuccessful. In this situation, the only way is to place a cover stent on the left main. Very unelegant approach that really goes to the memories, but something should not be done at all. But if it happens, this is the only solution. Keep a balloon inflated proximally. Try, if you can, go distally, but if you cannot, after multiple attempts, the only way is to place a cover catheter. Always monitor a perforation. This is a diagonal perforation from a loop, big loop on a wire, should not be done. Prolonged balloon inflation, the perforation was taken care. Thanks God there was something to do on the LAD, and after a while you see that the perforation comes back. If this patient would have been sent to the floor, would have been a problem. So do not assume that a perforation that is taken care by prolonged balloon inflation is cured. Stay there a little bit in the Cath Lab and monitor and make sure that your result is stable. In this case, we place a cover stent on the LAD and treat is low flow or no flow. This is very bad complications. If it's localized and small, nothing happens. But the worst is to place a stent when slow flow is a problem. So do not assume that slow flow is due to a dissection. Slow flow is slow flow, and the treatment of slow flow is not to place a stent. Here is a typical example of a slow flow. Dr. Latib may remember these. And he put a balloon distally, a broken balloon on purpose, and injected dye. If the dye, instead of going distally, comes back proximally, this pathognomonic or slow flow or no flow. In this case, you go distally and you inject nipride, adenosine. Lately, we really like to use adrenaline, especially if the patient is hypotensive, 100 micrograms, but you can go to a lot. You can even inject 1 milligram of adrenaline selected in the vessel to correct slow flow. And if the patient does not recover, impeller, much better than balloon pump, is the way to go. And remember and consider, this is my last slide, frequently is the second sequential mistake of the operator or problem that put the patient in serious trouble. So when you have a complication, you attempt to solve it and things do not go the way you like. Be patient and think profoundly, but you are not allowed to make two mistakes. One is okay, but two are a problem, and three are a drama. So think, evaluate, and understand why a problem occurs before implementing a possible solution. This is the most important message that I would like you to remember from this lecture. Thank you for your attention.
Thanks, Antonio. There was, as usual, I mean, there's a lot to take in. There's a lot of great tips and tricks from, years of your experience. I'm going to open it up a little bit to the fellows, and then we'll have Eberhard and Juan make some comments too. But we have a whole lot of fellows on, so if the fellows can come on, Manaf and Shun, and see if you have any questions. And if there are any questions for Antonio from the participants, please, write a chat or raise your hand and we'll let you speak. There was one comment from Dr. Wilson just saying, we should give this talk on July 1st for the interventional fellows. Well, I completely agree with you. There's so many great tips and tricks here that I've learned from Antonio over time, but this is kind of one of those talks to go back to often and just go listen to it again, because there are lots of things embedded here that are very important.
Azim, can I ask a question?
Please.
So Antonio, as Azim said, filled with a lot of experience, the whole coronary field owes you a lot. We are being used, that you use very high pressures. You so said, I go up to 44 atmospheres. Most of the time, you don't even have manometers to go that high. So 2 questions for you. Number one, when do you decide to go femoral versus radial? Because you said, let's not forget about femoral. The majority of the young fellows use radial now, are trained to do radial. What is your opinion on that? And the second is, when do you really use high pressures? And with high pressures, I really mean above 20 atmospheres.
Yeah, okay. Femoral has intention to treat. Not if I fail radial or radial is absent, of course. Femoral has intention to treat. When I have a very complex coronary, I prefer to go femoral. This doesn't mean that you cannot go radial, but I prefer to go femoral if I have a complex coronary.
So, complex coronary, let's just clarify, Antonio. So, a very calcified, difficult left main where support's going to be an issue, tortuous RCA maybe where you think you'll need a lot of support, maybe a CTO, a difficult CTO.
Yes, or a long LAD where I have to do couple of bifurcations, maybe left main. Left main by itself, single, is not an issue. But left main and 2 big diagonals on the LAD that needs to be treated. So maybe I go femoral. And if I do total occlusions, they are the experts, so I don't want to take them away, but I prefer radial and 1 femoral. I don't like double radial, but it's okay. And if I use hemodynamic support, I go both femorals. I don't think you need to stick one femoral, you stick both. What the hell? If you're already doing femoral on one side, patient is not going to move anyway because you have impella. What is the point to do impella in one? Okay, it's okay. But if I do hemodynamic support, I use two femoral. And to the high pressure, I'm not enthusiastic to use 40 atmosphere. I'm always a little bit trepidant about vessel rupture, and I hate vessel rupture because it's a drama. I lost patient because they had vessel rupture. So nowadays, with modern devices, you should minimize the need to go to 40 atmospheres. But if I have to go, I do IVUS first. I want to be absolutely sure that the vessel size is like that, and I undersize a little bit the high pressure balloon, always. And always think in my mind what kind of cover stent I will use, how to go, because can happen.
Can you, I'm sorry.
Yeah, just one thing I want to make a comment about the radial femoral, Antonio. One of the things for everybody I've always learned from you and I've admired and I tried to copy in my daily life is you've always had the ability to change your practice as new data becomes available, even if it makes you feel uncomfortable initially. So I remember when I first came to Milano, you only did femorals. All of us younger people were switching to do radials and you stuck to femoral, and then you switched as well. And you started doing many of your cases, even complex cases, via radial. Can you maybe just share with, because in America, there's still a lot of femoral. Can you maybe just share with some of the audience why you switched to radial in your own practice?
Oh, radial should be the default approach. For 70%, 80%, maybe even more, should be radial. Radial, first of all, you learn. You have to learn to stick the radial, okay? But you have to learn to manipulate the catheter. But then, the patient, you don't have the bleeding issue. You do not have the bleeding issue. Patient can move. The nurses on the floor are happy, but not happy because you want to make the nurses happy. The nurses are happy because they don't see complications. That's the reason why they are happy. With all respect to the nurses, I don't do radial to make people happy like that. People are happy when they don't see complications.
Excellent. Sorry, Aberhard, I interrupted you. You were going to say?
Well, I agree with Antonio. I think basically he followed the mainstream because we all trained in femoral. We felt very comfortable. What I do see though, and that goes back to your very first statement, Antonio, which is fundamentally important. If you do an angiogram, make sure that you get the information that you need. The worst is if you get a wobbling catheter because you don't know the radial approach very well, the catheter, the guiding catheter is not engaged correctly, you have bad opacification, and you say, well, I think everything is okay. This is a bad compromise, and much rather than doing a bad radial, just think about it beforehand. Even though I agree it's default, but I still see many, particularly older physicians that are not trained that well, that do insufficient angiograms, and that's about the worst. If you don't get the information of the angiogram, then you have to repeat everything and you don't get the information that you need.
Absolutely, Eberhard, what you said was told to me by Dr. Gensini in Syracuse about 40 or 35 years ago. He told me, Antonio, the worst complication of a coronary angiogram is a non-diagnostic exam. This is the worst complication. Non-diagnostic exam. After you do the exam, you do a stress test or a scintigraphy. My God, to do a scintigraphy to find out if the lesion is critical after a coronary angiogram, unheard.
There's one more thing, Antonio and Azim, and then I shut up. The one thing is, could you please say some words about patients post-bypass surgery? How do you approach the bypasses when you do suspect a lesion or you do half a lesion? What is different in your approach? I'm saying this because, as you said, some really bad complications will never get out of your mind. And what I did at one time, I injected manually into a fragile saphenous venous bypass with high pressure, even manually, and the bypass ruptured. So tell us a little bit about your approach to bypass surgery, just the protection, different pressures. What's your approach?
But if I have a mammary, and most of the time is the left mammary, I use the left radial.
Mm-hmm.
If I have double mammary, I use femoral. If I have a vein graft on top of left mammary, I use left radial, and most on the graft I use amplats, and for some right I use the multipurpose. One issue that I did not cover is about using guiding catheter with a wire in patient with high creatinine. In general, especially if after bypass that you have to look for the graft, I start with the guiding catheter, and instead of checking with dye if I am in the graft, I advance the wire. If the wire goes in, I am in, and I saved a lot of dye. It's amazing how much dye you save by using a almost angioplasty approach, using the wire to probe for the presence of the hole to go in. And
are you to prevent slow flow when you dilate or stent a bypass? Use protection.
When I dilate a vein graft, thanks God, is something that I did it in the past. I still use protection devices, but it's not a guarantee against low flow.
Nope.
I don't know how to. The only way to prevent low flow is not to be aggressive in bypass, not to over post dilate. If you post dilate too much, you squeeze. But maybe Azim will remember, because it's a long time I don't place a stent in a graft. Many years ago I did it.
Yeah, no, it's amazing how few SVG interventions we do anymore. Because I think most of us now will try and open the native vessel as well if we can. And tell you one other comment that I often try and explain to the fellows, but I'd love for you to explain, is the fact that when you're trying to advance a balloon or advance a stent and you feel resistance, not all resistance is due to the fact that the lesion needs to be more aggressively prepared. Some of it is friction that can be overcome in other ways. So by changing the position of the guiding catheter, by making a patient breathe, by putting in a wiggle wire, can you maybe just comment on that too?
Yeah. Changing the position of the guiding catheter is very important. Amazing. Sometimes you can get a stent or a device by pulling out the guiding catheter, not in, and the device goes in more physiologically. So frictions, sometimes by injecting dye forcefully while you advance, that will make the thing friction. Or while you try to advance, pull back the wire a little bit. So these are all maneuvers, but changing the angulation is fundamental. That's what you do with a wiggle wire, but you can mimic. Sometimes you can even pull back the wire a lot and go to the floppy part, and then the stent on the floppy part will find its own angulation. So change the angulation. Like in life, strong action may not be better than soft and way to deal with the problem with kind of deceiving persuasion.
Deceiving persuasion. I like that. I'm going to have the fellows. There's some questions from the participants as well and from the fellows. I'm going to pass it on to Manaf and Shun.
Thank you, Dr. Colombo. Very insightful as always. We always appreciate your talks and look forward to them. One question I had was something you had mentioned briefly.
Can you speak a little louder, please?
Yes, sorry. One question I had that you had mentioned previously or briefly in your talk was about leaving edge dissections alone, especially if they don't have a pressure gradient across them. I was just hoping you could talk a little bit more about that for those of us who didn't happen to catch your prior talk on this, and to maybe give us a refresher on your experience in leaving these dissections alone.
First of all, I want to clarify that I'm not making a statement that dissection should be left alone. Okay. And stents are meant to be implanted. Nevertheless, you should not always treat even a small dissection. Sometimes you have tiny dissections that you can leave alone, especially if you see that the residual lumen is large. How can you make this decision? First of all, should you make this decision? Or should you just implant a stent and close? I tell you, I do not have the answer to this question.
I do.
Okay, Eberhard has. Tell
Depends on Antonio's mood.
Tell.
It depends on your mood. It depends on what mood you're in.
No, but we have young people listening.
Exactly, that's why.
We have to be precise. We cannot, of course, everything depends on our mood. But I do not know, because sometimes placing an additional stent is very simple. But sometimes the additional stent is a long stent, and going from healthy to healthy is okay if you're treating a short lesion, but if you treat a long, so I think, and this is for you and for all young interventionists, let's do some study, let's do something to come out with some science out of this perception. I have the perception that you do not need to stent long and to go from healthy to healthy and to cover any dissection. And that you can do pressure gradients to something to evaluate if the dissection needs to be treated. But we need to generate data because we cannot go by our feeling. So to generate data, we need some kind of study. So please, you are the future, you are the new generation. Let's try to generate data, because I had a presentation this morning with India, and it's amazing how diffuse disease they have in that country and how much they use full metal jacket. So if we can teach a way to limit a little bit stenting, not to go to spot stenting. People hate the word spot stenting. That's not spot stenting. But to limit a little bit full metal jacket and use pressure gradient or some other way. And now we have a drug-coated balloon. Soon you will have it in the United States. I think will be a big contribution to the field. So you are the people that are have this responsibility. Make the field, make a jump a little bit and learn when you do not necessarily need to stand long.
Thank you. That's fair. Shun, do you want to take the next one?
Yep, thank you. So there's a lot of questions from the chat, but the one question that I'm very curious to ask, so if there's an ostial lesion, the left main or the RCA, what is your tip to not miss the ostium, especially if there's a lot of heart motion with the respiration, and if the stent does come out, protrude out too much, would you ever consider stent extraction, which is an interesting question because I actually had to do that when I was a fellow in Japan. My attending did it, and he made me present at a local meeting, and I was scrutinized by professors of the university. It's monstrous to take it out. It's how dare you do that? We stented it, and patient did well, but that's an interesting question I wanted to ask you.
Okay, to stent the ostium, first of all, I never use 8mm stents to stent the ostium. Or never, rarely. Because sometimes if you place an 8mm stent, the stent does not anchor very well and may come out by itself. So maybe from some very short left main, you may have to do that. But for other than this situation, I use 12. The stent is always to protrude a little bit. Don't take these ideas that has to be perfect. It has to protrude a little bit. And try to use a stent that is not visible, so you don't get this drama. How much I protrude, how much I don't protrude. But protrude a little bit and then post-dilate with a semi-compliant balloon, with a non-compliant balloon first, and then a semi-compliant balloon to make it a little bit like a flower. I don't think you make it like a flower, but at least in your mind you pretend that it is a little bit a flower. And the ostial lesion needs to be prepared very well, but be aggressive, not too much, because you don't want to dissect the aorta. Don't dissect the aorta because it's a bad complication. So try to balance, but message, protrude, not too much, but protrude a little bit, post-dilate, sometimes with a semi-compliant balloon just to flower, and maybe jiggle the guiding catheter up and down with the balloon inflated. But I tell you, aorto-ostial lesions restenoze a lot. I don't have.
So, having said that, Antonio and Azim, by the way, you have the ostial balloon. I'm sorry, the ostial
flash
stent.
balloon.
Exactly, the flash.
Yeah.
I tell you, I have used that.
Yeah.
Everything that Antonio said, and I actually like to remind him that we have young physicians here, when he said, you know, you wiggle a little bit, this and that, and this and that. But the point is, you know, it is a very difficult question, because if he says on one side, you know, ostial lesions restenose a lot, and you have a stent protruding into the aorta, it's a hell of a time to get back. Then you have to use different techniques that he didn't explain how to get, if you're not able to intubate a protruded stent, then you have to use a different technique in order to get into the vessel. That's a little bit more complicated. So I think it is important that you try to be as close to the ostium as possible. And that is a very relevant question. And I'm wondering whether the ostial stent, the particular ostial stent, doesn't have a value in order to overcome this problem. You know, because it's a trumpet-like thing. It's very easy to be used, you know.
I haven't used it yet, but I know there have been some comments from on the chat, and I know Dawn, thanks for joining, Dawn. Let me know if you want to actually speak. I'm actually going to promote you. She made a comment that, you know, I think she's used it. I'm going to actually ask her to make a comment about the balloon. It's, Antonio, I think we saw this for a while. It was available in Europe. It's a special balloon that has a distal part and then a larger part. So it allows you to really expand the ostial part. Dawn, thanks for joining us. Maybe you want to comment. Have you used ostial flash?
Yeah, good morning. Oh, terrific
Morning.
talk. I'm so glad you invited me. Yes, we have the Ostial Flash. Like many things, I think it was adopted from peripheral intervention for renals and mesentery.
Right.
But it's you size it's a double stent. So one stent is sized to your vessel, and then there is a large balloon, a 6 millimeter balloon at the edge, which is a low pressure 2 atmosphere. And so you place the marker of your sized balloon inside the stent where you believe the ostium is, and then you hand inflate this circular large balloon to just what Dr. Colombo is talking about, to try to flower or purposefully longitudinally deform the stents that are in the aorta back onto the ostium of the aorta. Wow. And, you know, it's bulky, but you're only getting it into the ostium. You have to, you know, carefully position it. If it's out too far, it's not going to work. If it's in too far, I don't think you're going to harm the vessel because it's such low pressure, but it's probably not going to do what it's intended to do. I always do this followed by a high pressure post dilation of the ostium with a non-flash balloon, because I'm not sure how the longitudinal deformation is going to occur and whether that's going to affect restenosis. So I generally only use it when there is, you know, more than 2 millimeters extruding by IVUS. If it's just a small amount of protrusion, I would leave it be. It's good coverage, but it's only for really, you know, when it's out just too far and you're worried that the guide is going to keep deforming it. That's the one thing, is if, you know, re-intubating these arteries, even while you're working on them without deforming the stent.
So it's a balloon, right? That can be used in any commercial stent, any commercial drug-eluting stent.
Correct. Yeah.
Correct. It's balloon.
Position and dilatation.
Yeah, it comes in different sizes, like 3.0 to 5.0.
Okay.
3.5, 4. And so you size it to your vessel size. And then the flash balloon, which is the circular flowering or crushing balloon, just crushing doesn't sound so good, is all the same size.
Right. Okay. I think we're going to try it. We're going to get some to try it. I haven't tried it
It's
yet.
very nice. It's really nice.
Available. I mean, if Dawn's used it, then I know it must work. So I'm going to try it. It comes now highly recommended. Antonio, there's one question I wanted you to address from the participants, because it's something I learned from you. And you actually showed 2 cases today where there was a balloon rupture and then there was a vessel perforation. Now, many people, I don't think, understand the mechanism why that can happen and what you can do to prevent vessel perforation or vessel injury from balloon rupture.
Yeah, I always say, thank you. I always discuss this. When a balloon ruptures, the dye does not get ejected against the wall. Okay? When the balloon ruptures, the dye goes distally and proximally, most of the time distally. Why the dye makes this burst? Imagine I'm sitting on this chair and this chair ruptures. I don't hit the ceiling, I hit the ground. So the balloon, the force of the dye is caused by compressed air and by some elasticity in the shaft of the balloon. But if you have a minimal or no compressed air, the trauma to balloon rupture is minimal, because it's only the elasticity given by the shaft, which is a little bit compliant. So my lesson, people don't do, and I don't do it as well. If you are inflating a balloon at very high pressure, make sure that you have removed all the air from the balloon, because this burst effect will be maximized if you have compressed air in the balloon. The best way to make the air go away when you're inflating the balloon is to go to high pressure. You see that the balloon feels very well if you go to high pressure, because all the air gets compressed. So try to minimize the amount of air inside the balloon.
Maybe a couple more questions, Antonio, quickly. There was a question actually from Dawn. Dawn, if you don't mind, I'll ask you a question. Just because they're young people here, and we want them to get the right messages. I mean, in which cases, when you perform a diagnostic, you will not perform an ad hoc PCI? Are there cases, or do you always just go ahead and do PCI after the diagnostic?
But,
so, for example, if you have, you do a diagnostic on a 45-year-old, and you find he has distal left main disease with a complex distal left main, will you just do the PCI, or do you stop? You take the patient off the table, have a discussion, and are there other anatomies where you would do that?
First of all, when at the end of the case, in my mind, I have the idea, I'm not sure if I should do, I don't do it. So if I get this suspect, I should not do, I don't do it. Then, of course, there's the usual stuff. I don't go to if the patient is not informed, the family, etc., etc. Of course, if those are clear. But if I see that I don't have a good guiding catheter in that approach, if I am a radial and the guiding catheter is not performing well, I don't insist. I say I do the intervention next day utilizing a femoral or a right or left radial, different. So poor support, and I don't believe I can overcome the poor support. A lot of dye, of course, and I have some suspicion. For example, yesterday I did a diagnostic, and I found the patient with bypass on the mammary and stenosis in the proximal LAD that goes into a septal. And I hate to do this kind of massage, this proximal LAD to a septal. So I was not convinced. And patient is having poor LV function, and he says maybe it's due to that. I look at an old film, and it's a little bit bad, worse, not so. I wanted to check better the old records to make sure that what I'm doing is appropriate. So I told the patient, I have to evaluate, and then I'm going to do it the PCI tomorrow, because I evaluated. So when you have to acquire more information, nothing wrong to delay, nothing wrong, but it's better for yourself. If something happens, at least your mind is clear that you have done something appropriate, not just because you are there. I'm here, so what? I just place a stent, let's place another stent. What are you crazy? Because you place one stent, you take another stent. I mean, this is not the way. This is, we are doctors, we are not a stent placer.
I like that comment, absolutely. There's also a few people on the chat who ask the same question in different ways. So, we still, and I even have this discussion with the fellows often, there's a tight ostial stenosis of either, the LAD or diagonal or circumflex. And the question is always, do you try and place a stent to be precise, or do you cross over the stenosis to be sure you treat the stenosis? And I think it's particularly relevant maybe for an ostial LAD stenosis, where there's discussion, because in many people's head, the minute you put a stent in the left main, even though it's just there to make sure you cover the lesion, you're now treating the left main. So any, advice for the fellows on how you deal with these?
First of all, it's always nice to be precise and to cover the ostial lesion. Nothing wrong, but do not be naive, assuming that the way to prevent reintervention is to be precise and to cover ostial lesions. Most of the restenosis occur inside the stent, not at the margin. Some occur at the margin, but not most. So unfortunately, even if you are precise and good, you may still have restenosis. So be precise, but don't over-inflate the fact that being precise is a way to avoid restenosis. A little bit more complicated, the issue.
Yeah. Great. Munaf or Shun, any last questions for Prof. Colombo before we let him go?
No, not from me. Thank you very much, Dr. Colombo, for a great talk as always.
Thank you. I really, and thank you for Azim that really made this stimulating, and Eberhard. I always like to see the face of Eberhard. It gives me enthusiasm.
Antonio, thank you so much. It was great again.
Thank you,
We all
Antonio.
learned so much. We appreciate it. Eberhard,